Good morning, everyone. On behalf of the department, I'd like to welcome you to our neurology grand rounds. It is my honor to introduce our speaker today, Dr. Michael Sperling, who will be sharing with us his expertise on a topic of utmost importance, namely mortality in epilepsy. Dr. Sperling is Baldwin Keyes Professor of Neurology and Vice Chair for Research at the Sidney Kimmel Medical College at Thomas Jefferson University, and director of the Jefferson Comprehensive Epilepsy Center. He is an internationally recognized clinician scientist in the field of epilepsy, known particularly for his work in clinical neurophysiology, epilepsy surgery, and investigational therapeutics. He's published approximately 500 peer-reviewed papers, reviews, and book chapters, and several books. He's presently editor-in-chief of Epilepsia and is former president of the American Clinical Neurophysiology Society and the Philadelphia Neurological Society. He received the J. Kiffin Pendry Award from the Epilepsy Society in 2018 and the Ambassador for Epilepsy Award from the International League Against Epilepsy in 2021. It's my pleasure to invite Dr. Sperling to begin his lecture. Thank you for joining us.
Thank you very much for the introduction and the invitation to speak. I sort of wish I were there. It's convenient not to be there. I've visited downstate a few times. I've been there in the old days when Dr. Krakow was chair, and it was very nice to see everyone then. I hope at some point we get to resume slightly more normal circumstances for visiting lecturers as well. I was asked today to speak about mortality. I gave a choice of topics, and this was what was requested. And I'm going to take a broad view, and then I'll talk about potential interventions in the latter part of the talk as well. Please feel free to interrupt as you wish and ask questions. We can try to be a little interactive despite the online pattern of this, manner of this talk. With regard to disclosures, what I'll say is that they've been posted with downstate. None of them are terribly relevant to this. I have no personal financial interest in anything, although I've been engaged in therapeutic research. So in the past, I've been involved in development of multiple medications, drugs, including cenobamate that I'll talk about briefly, and neurostimulation, and have had a lot of involvement in epilepsy surgery. No personal gain in any of it. All the research contracts have funding that's gone to Jefferson, not me. So mortality in epilepsy is important because unfortunately people with epilepsy are more apt to die than people without epilepsy when you control for age, sex, ethnicity, etc. The standardized mortality ratio, the SMR, is 2 to 3 times higher, and it's very much higher in subpopulations. So the most horrifying paper I ever read about this was a study in Norway, where they found that people with intellectual disability and epilepsy had a 40 times higher risk of dying compared with the general population who were age and sex maxed. And then if you added in a little cerebral palsy, the risk was 50 times higher. So their neurologic comorbidities makes a tremendous difference as well in this, but epilepsy itself has been 2 to 3 times. And again, more severe types of epilepsy often are associated with comorbidities, and the mortality is high. And what proportion is due to the epilepsy and what part is just related to the comorbidity, because intellectual disability without epilepsy also has an increased SMR. So the other figure I have here, and this is a paper from Lars Forsgren, again, a Scandinavian study. Survival in children is 94% at 10 years and 88% at 20 years. We don't think of 12% of children being dead 20 years down the road after diagnosis from any particular disease like epilepsy. Now, this again incorporates everything. So the kids who have coexisting significant more neurological morbidity, chiefly intellectual disability and cerebral palsy, but may have other causes too. Maybe their epilepsy was due to a tumor, for example, or stroke. So morbidity is high. It's a high public health burden. While the cost of epilepsy, on average, is not as high, perhaps as some other diseases, The people who have uncontrolled seizures account for well over half of the cost of epilepsy. So from a public health point of view of health expenditures, it's very high, largely in people who seizures are not fully controlled. But it's also an important cause of lost life in high and lower income countries, and also lost productivity. So many people are disabled and not working at all, or only partly employed or underemployed in lower income positions than they might otherwise have. Educational attainment is reduced. So it's a public health and an economic burden, which is significant, and it applies everywhere. I'll talk about what we know about mortality, insights regarding cause, pathophysiology, and prevention. So what are the causes? So as I mentioned before, underlying diseases and comorbid conditions are important. In adults in particular, why do people develop epilepsy? And a lot of it is uncertain, but as we age and time passes, the common causes of epilepsy are stroke, cardiac disease associations, which is probably cerebrovascular really, and cardiac disease is a comorbid condition, neoplasms, either primary or metastatic, infections, degenerative diseases, and dementia. Rates of seizures go up tremendously in people with dementia over time. And there are congenital causes. And I guess one of the things that we should point out is that there's no such disease as epilepsy. There are the epilepsies, and often epilepsy is really a symptom of an underlying condition. The person who has a stroke and develops seizures has epilepsy, but the fundamental problem was a stroke, or the person with a tumor, same idea. And there are epilepsy-related causes directly, however, of mortality. So not only that disease, the cerebrovascular disease or neoplasm, but epilepsy itself can cause death. How? Through status epilepticus, through seizure, and through SUDEP. So the sudden, unexpected, or unexplained death in epilepsy that's been reported, and tells you everything we understand about it. Sudden, unexplained, or unexpected is a problem. And this is what gets the publicity. It's actually a minority of the cause of death. So we spend, as doctors, a lot of time talking about the less common rather than the more common. When you think about SUDEP in epilepsy, that applies as well. Much attention, a lot of funding devoted to this, which is a less common cause of mortality. Seizure-related injuries such as pneumonia, injuries, drowning also happen. Unfortunately, every few years, I get a call from a patient of mine who was driving a car and perhaps had been seizure-free or not, and was killed in an accident or seriously injured. And then they're epilepsy-related, but not necessarily directly. So I had the SUDEP there. And then there are drug idiosyncratic reactions, and those are really quite rare. The odds of somebody dying from an anti-epileptic medication, and the new preferred term is anti-seizure medication, is really very, very, very small. Suicide, however, is not so small. Depression is common in people with epilepsy, particularly those with uncontrolled seizures. And the risk of suicide is 10 times higher in people with epilepsy than people without epilepsy, 10 times higher risk of dying of suicide. And then unrelated causes can play a role too, as I said. A lot of attention is focused on SUDEP, which I'll discuss, but first I'm going to talk about other causes. And our knowledge is limited really by the accuracy of medical examiner reports. And whenever people go into the weeds and look at what the medical examiners have written as cause of death, often it's not correct for people with epilepsy. It's a real problem. And we have a series of really excellent medical examiners around the world and in this country certainly, but for some reason people with epilepsy, often the epilepsy is either blamed or not even attributed, and it's often a problem. If you're 20 years old and found dead, they call it SUDEP if the autopsy is negative. If you're 65 years old or 75 years old, it's called myocardial infarction, even when you don't see it, a cardiac death, as a simple example of that. And and then there are confounding comorbidities too, because there's a real question: does epilepsy increase the risk of comorbidity and increase the risk of death? There's data now that the old-fashioned anti-seizure medicines and some of the newer fashioned ones, like cenobamate, for example, which are significant enzyme inducers, may be associated with worsening profiles of cholesterol, increased lipoprotein A, increased CRP, C-reactive protein levels, and all of this which potentially poses an increased risk of cardiovascular mortality and cardiovascular morbidity, and risk of cancer seems to be higher too. And again, are some of the other issues, people with epilepsy in many places are reported to be more likely to smoke, more likely to have substance abuse. You know, these may make a difference as well, and epilepsy may be a contributing factor. The three most common causes of comorbid disease causing death are non-cerebral neoplasms. So people with epilepsy still get lung cancer or breast cancer or colon cancer. They still have myocardial infarctions and strokes. And in fact, nearly 60% of the deaths in a national general practice study in the UK, it was 550 total, were due to these three most common causes. And SUDEP and status epilepticus accounted only for 3% of deaths. This is a nice paper published by Mark Kieser at the University of Montreal. And this is the overall table from Mark's study, underlying cause of death. And you can see the most common causes, the proportionate mortality ratio. So non-cerebral neoplasm, cardiovascular, and cerebrovascular disease on the left, very high. The other is a grab bag of many little things. Then you see primary CNS neoplasm, pneumonia, pulmonary embolism, external causes, whatever that means, congenital disorders, etc. But these are the big ones. These are why the people die with epilepsy by and large in that big national general practice study. And the data is pretty good from the UK. What were the immediate causes of death? Well, to go back, maybe you have a breast cancer or lung cancer, maybe you have a myocardial infarction. But why does it happen? Pneumonia, cancer related, not otherwise specified, and then myocardial infarction or congestive heart failure. So and then acute stroke, for example. So somebody has a stroke, has seizures, and then dies relatively soon, and it's really a stroke death, but the person has epilepsy. And again, directly seizure related as the acute cause of death is very uncommon. Doesn't mean it doesn't happen, but it's not the most common in the population. It's reflective of the causes of the different types of epilepsy that people have. What about the duration of epilepsy and the cause of death? And this is something that's been talked about. So if you look at this, the red are cause of death directly related to the epilepsy etiology. So the person who has a stroke causing seizures and dies of the stroke, that's a cause of death directly related to the epilepsy etiology, for example, or a metastatic tumor to the brain. An epilepsy-related death or due to external causes, an accident, for example, would be in orange. Cause of death unrelated to epilepsy etiology, the cause is in blue, and then in gray is, in people who just have idiopathic or cryptogenic epilepsy and then die. And you can see in people with idiopathic or cryptogenic epilepsy, not very many of them die early on. It does happen, however, but that's a smaller proportion of the deaths, and some of these are probably SUDEP. And as the longer epilepsy goes on, the greater this gray bar becomes as a proportion of the death. So it's more than half by the time you get to 5 years to 10 years, and it increases further. Whereas the acute causes related to the etiology, the stroke, the tumors, et cetera, are very high in the early years because these are often conditions associated with high mortality, cardiovascular disease, stroke, and cancer, and people die from them early. So the duration makes a difference. And as you can see, though, the fact that idiopathic or cryptogenic, which could be a genetic cause or unknown, over time is associated with death. Now, what about age? And this is a problem. So the standardized mortality ratio is not the same as the risk of dying. Obviously, somebody at age 80 or 90 is a much higher risk of dying in any 1 year than somebody who's age 20. And that's going to affect the standardized mortality ratio to a certain extent, or a large extent, actually. So that for young people under 20, overall, the risk of dying is 6 to 8 or 9 times higher. And this really holds true up to age 40 or so. So people typically, when they have epilepsy, it's not from strokes, it's not from myocardial infarction, it's not from malignant cancer. As we age, unfortunately, those bad causes come in, and since the background death rate increases, the standardized mortality ratio drops. So it doesn't mean that epilepsy is any less serious, it's just that unfortunately, risk of dying tends to increase as we age. And these are from a few a few papers. There are papers by Alan Hauser, who's at Columbia, and Olofsson in Scandinavia and Sweden, and Sam Latu, who's now in University of Texas in Houston, published papers a long time ago at this point, And then it was interesting, the numbers were relatively similar in terms of what the SMR is, duration of epilepsy. And again, your duration could be short and you could have started at age 2 years, or it could be short and you could have started at age 20 years or 80 years, in which case, if it starts at age 80 years, you're not going to get 20 years worth of standard, of follow-up probably. So it makes a difference. So that's again confounded by age and etiology. So what's the interpretation of excess death? It's the rate is elevated in people with epilepsy. Non-SUDEP causes are predominant. A portion of the excess mortality is explained by the illness, the stroke, the tumor, dementia, etc. But much of the excess cannot be explained by comorbid factors. And the question is, does epilepsy increase risk for comorbidity? And I think the answer to that is yes. It's related to primary disease processes. Might our treatments do it? Yes. Anti-epileptic drugs or anti-seizure medications may increase the risk. There are some studies, as I said, showing worsening factors related to cardiovascular risk. There are other studies suggesting that drugs may impact the immune system, immune response, which could lead to an increased risk of infection, lower ability to fight infection, and perhaps worse cancer surveillance. And then there are mixed causes. And really, there's insufficient research in this area since the research focuses on SUDEP, which is important, but it's a minority of the excess deaths, and nothing has really changed in this regard. And this is really a ripe area for good clinical research. Unfortunately, it's very messy and difficult because of the confounding factors. Now let's talk about SUDEP. After telling you that too much attention is focused on it, I'm not going to focus on it, naturally. And a lot has been studied, and the pathophysiology, we have some ideas, but it's still not entirely proven. So it is an important cause of death in subpopulations with epilepsy. So young people who suddenly die without reason, and the highest rates are in young people and young adults and adolescents. And these are people you don't expect to die. I get a phone call, our most recent phone call, one of my colleagues last week. Told me he saw a new patient in the office on Tuesday. It was a young man in his early 30s, and he got a call from the man's wife on Thursday that she woke up in the morning, he was dead in bed. And my colleague was just shocked and horrified by this. It's a scary thing when it happens, and it's not great in that regard. The incidence is as high as 9 per 1,000 person years for refractory epilepsy. And if I could ask somebody, Alexandra Resnikov, if you could turn your microphone off, please, because there's noise coming in the background. So the incidence is as high as 9 per 1,000 person years in refractory surgery patients, to as low as 0.35 per 1,000 person years in community surveys. It's almost certainly under-recognized and under-reported. And the estimate overall for people with epilepsy in general, and this is a mixed group, is 1.6 deaths per 1,000. But if you look at that worst one in the refractory candidates, 9 per 1,000 person years, over the course of 10 years, it's a lot of deaths that you see. That's 1% of the population that has died in 10 years, which is high. If we look at the rate based upon where the patients are and what they have, you can see population-based rates of SUDEP are low per 1,000 people with epilepsy in person years. Population-based, it's maybe 1.2%, 1.2 rather per 1,000 person years. In epilepsy clinics, who tend to attract somewhat more severely affected people, the rate is nearly double that. It's 2. We look at people in residential care or intellectual disability. There are some studies that I say it might be vastly higher as a standardized mortality ratio, but the rate is 3.5. Refractory epilepsy, 4.2, and then people who referred for surgery or VNS, so they're not only refractory, but they're the harder refractory. Someone has 2 seizures a year, that person's refractory. That person might never be referred for surgery. The person with 2 per month is much more likely to be referred for surgery. I wouldn't say that that's appropriate. I would consider somebody who's having 2 per year, but the risk is even higher. If we look at people who are enrolled in add-on drug trials, so this is a paper published, 22 years ago nearly, in 4 different drugs. The drugs were not identified because the manufacturers did not want to be associated with the word death in their drug, but 4 different drugs, just called drug A, B, C, D. You can see the number of patients, how many people were in the trials that were published with the FDA. 1,500 to nearly 3,000. So overall 9,000 people. How many person years of use? We have several thousand. And you can look at the mortality overall, and you can see the mortality rate overall. And this is a standardized mortality ratio, 8 times higher, 11.9, 9.4, 7.8. These numbers are in the same ballpark. This is the confidence interval around it. If you look at SUDEP and accidents are significant. You can see where it is. And then again, you can see if you pull out the accidents where the SUDEP rate is. So not surprising that accidents maybe represent a quarter or so of the combined SUDEP and accident rates, about a quarter of the rate of the SUDEP or so. So it's significant. And these are people just in trials who unfortunately died for whatever reason, not related to the drug. What's the mechanism that's been proposed for SUDEP? And there's a suppression of brainstem function, arousal, and what people think is most cases are probably respiratory depression. And I'll show you a little more data about that in a little while. So that people have a seizure, there's a postictal suppression of brain activity, and in particular, a postictal suppression of respiration, and they stop breathing and then develop a cardiac arrhythmia and die. A primary cardiac arrhythmia is also a possibility that is thought to account for less of the a minority of the cases of SUDEP. But why does it happen? Why do you have a respiratory depression and not recover breathing is not so clear. And although I'll show you a little data in a bit about that, because it appears that it might be potentially a factor that could be altered. What are the risk factors? And they vary somewhat between studies, but the one risk factor that never varies is having uncontrolled tonic-clonic seizures. So people with tonic-clonic seizures, this could be primarily generalized or focal to bilateral tonic-clonic seizures, a patient with focal epilepsy who then spreads and has a full-blown convulsion. These are the people who are most at risk of dying. So can you have more minor seizures and die? Yes. So what we used to call complex partial, what are now called focal impaired awareness seizures, are associated with an increased risk of death, but not nearly as high as tonic-clonic seizures. And the magic number for tonic-clonic seizures seems to be 3 or 4 per year. Once you hit either 3 or 4, depending upon the studies, the risk doesn't go up. 3 per year, 30 per year, the risk of dying is about the same, or 300 per year. Your risk of injury goes up, but the risk of dying is probably not terribly different once you hit that number. So it doesn't take very many. The odds ratio of death at 3 or 4 per year is 15 times greater risk of dying than if you don't have any. 1 or 2 per year, 5 times greater risk of dying. And just having your seizures start as a kid, under age 16, so around puberty or a little before puberty, risk of dying is nearly double, 1.7. Being male is a higher risk, and whether that is related to gender or more likely, I would think, related to patterns of male behavior. So just like the risk of being killed by gunshot wound or stabbing for males is 3 times or 5 times higher than that of females, males tend to engage in more risky behaviors, drug abuse, medication non-adherence, higher risks in male, and perhaps that may account for that rather than the male gender making a difference. The duration, some studies say long duration of epilepsy, higher risk, maybe it doubles. And maybe that's because if you have a few seizures, it goes away and then you're no longer considered having epilepsy. Some of the people with short duration fall out of the equation. They grow out of it if they're kids. If they're adults, who knows, maybe they died from other causes, but they haven't died early on related to seizures. Seizures during sleep are riskier. So odds ratio is 2.6, and in some autopsy studies that have been done, typically somewhere in the neighborhood of 2/3 of patients who are found with SUDEP are found dead in bed. So you look, where's the location? Bedroom's the most common location, more than half, 60 to 70%. Occasionally in the kitchen, occasionally in the living room, but in the bedroom most commonly. And then in kids, as I said earlier, low IQ, abnormal neurological exam, and structural brain lesion are associated with increased risk. Now, SUDEP probably is ictal or postictal in the vast majority of cases. And again, this postictal respiratory depression is thought to be the most common cause, and a cardiac arrhythmia in some as well, perhaps, but less common. But there are reports of SUDEP without a preceding seizure. So patients who've been admitted to an epilepsy monitoring unit and died. I actually had one of my patients with intracranial electrodes who was fine. And then we just watched the EEG go flat and she stopped breathing and she died and she could not be resuscitated. And that's one of the interesting things about SUDEP, that resuscitation, once it's happened, is very difficult in these people, whereas you might be able to prevent it before the heart stops. And there are a number of other cases. Sam Latu had one. We had a paper, I don't know, probably about 8 or 10 years ago that was published with several cases, documented no seizure with SUDEP. So it doesn't have to be a seizure, but it usually is. And again, as I mentioned above, uncontrolled tonic-clonic seizures, the Mortimer study by Philippe Rivlin, who's now in Lausanne, Switzerland, found a strong association. And then here's the mystery to me. Many are susceptible. Why does it strike particular individual? And this is a question that I don't think we have an answer. Is everybody with uncontrolled epilepsy at risk, or only some at risk? So, just because you have tonic-clonic seizures, we know you're at higher risk, but not everybody dies. Now, again, as time goes on, people who didn't die in the first 5 years might die in the next 5, or the 5 after that, or the 5 after that. So is really everybody susceptible, or only some people? Do you have to have some other genetic susceptibility? Are some seizures particularly evil? They last 3 minutes instead of 1.5 on the one occasion, and the 3 minutes leads to a profound post-ictal suppression of brain activity and gives that respiratory arrest or provokes a cardiac rhythm disturbance. So this is really a mystery. And again, when you compare people who died, and this is a flaw of the papers and some of the ones I've been an author on, contrasting people who died with people who didn't die, what are the differences? And we can see having tonic-clonic seizures is a risk, but maybe everybody's at risk and it's just bad luck in some sense. And bad luck is having tonic-clonic seizures, clearly, and having lots of them is worse luck. We have cerebral autonomic and cardiorespiratory dysregulation. The suppression of cerebral activity, as I mentioned, has been attributed as potentially leading to SUDEP, but there have been some papers that have not been able to replicate that finding, including from our group. Moromi Ney, one of my colleagues, published a paper. We looked very carefully. The patients who were later found to have died of SUDEP and those who were still alive, there was no difference in that post-ictal cerebral suppression. Now, again, maybe because anybody could be liable to SUDEP. And again, another interesting thing is that if you look at people who've died of SUDEP and do controlled, case control series, you find that people who had died of SUDEP have less in the way of heart rate variability. So is this less variability in heart rate a factor that increases risk? Now, we know in adults, especially older people, heart rate variability is associated with cardiac arrhythmia and risk of death. So people with less variability are more likely to die of a cardiac death. So again, is this true in younger people? They have less cardiac variability, and that makes them to have a greater susceptibility to arrhythmia. So this could be a certain risk factor. Some of the people who die of SUDEP seem to have less heart variability than others. And then there's hypercarbia after a seizure. And then do these people who are not breathing, do they lack sensitivity to hypercarbia, and it doesn't trigger breathing the way it does in other people? So that might be a difference. So there's a defective brainstem regulation. Then maybe the brainstem becomes very accustomed to hypercarbia from seizures, and it can't kick in that breathing response to start breathing again in response to the hypercarbia. So again, possibly a problem. And then people have found abnormalities in brains of people in the brainstem and in MRIs suggesting various changes in certain nuclei and regions of the brain or brainstem in people who had SUDEP. The trouble is that since people with SUDEP have tonic-clonic seizures, we don't know if these are really just a function of having tonic-clonic seizures or whether they're really specific to SUDEP. And it's a big flaw in some of these studies. The NIH has been funding a multi-center study that we had participated with. And one of my friends published a very nice paper showing alteration in volume of certain brainstem structures. I forget which, it might have been locus coeruleus in one of them, in people who had SUDEP, but the trouble is maybe it was just tonic-clonic seizures and the studies didn't control for that. Is there a genetic susceptibility? So in a study of 61 SUDEP cases, this is a paper published in Annals of Neurology in 2016, 46% of patients had a previously reported pathogenic or candidate mutation. 4 of these patients, the 7 had mutations in genes associated with long QT syndrome, but there are plenty of studies saying that prolonged QT is not an important finding in SUDEP. 9 patients, 15% had candidate variants in dominant cardiac arrhythmia genes. Maybe that is a susceptibility factor. 25% had mutations or candidate mutations or variants in dominant epilepsy genes. Are these associated? And there were no mutations noted in genes associated with respiratory control. So again, might genes make you a little more susceptible? Yes, maybe. We don't have good data. And these imaging biomarkers and MRI research to characterize autonomic function and structural morphologic changes are all underway. And again, the big problem is if you compare SUDEP patients with living patients, we don't know if the latter are truly different. Perhaps they're equally susceptible if the right or more likely the wrong constellation of circumstances occurs. This is what I was alluding to earlier. Tonic-clonic seizures and being asleep make a difference. So this is a truly horrifying study in some respects, but it also suggests that maybe one might do something about it. No study has been done to demonstrate that you can reverse this, but the AAN actually has a guideline now about this. So if you look on the left, the 2 bars here, and I hate these 3D graphs, I must say, but you can see it. If you look at the odds ratio, because it's tough to tell where these are, but people with generalized tonic-clonic, and it really could be generalized or focal to bilateral tonic-clonic, the terminology is not correct in this paper. So if they have tonic-clonic seizures, the risk if they, and then this group have no tonic-clonic seizures. So let's start here. This is our reference, no tonic-clonic seizures and sharing a bedroom. So someone who does not sleep alone. And this is our reference risk of dying. And again, it's not the general population, it's just our epilepsy reference. If they don't have tonic-clonic seizures, but sleep alone, do not share a bedroom, the risk is 3 times higher. If they have tonic-clonic seizures and share a bedroom, it's 18 times higher. And if they have tonic-clonic seizures and sleep alone, it's 67 times higher. So again, knowing that many of these people seem to stop breathing and that apnea might be a cause of SUDEP is what happens that by sharing a bedroom, the bed partner is there and is stimulating the patient a little bit. In both of these cases, leading to a lower reference rate without tonic-clonic seizures than people who sleep alone versus tonic-clonic seizures still posing risk, but then sleeping alone 4 times higher nearly risk. So that is some stimulation, perhaps doing something. The person touching, talking, shaking, triggering breathing again. That's a question that has been posed. And as I said, the guideline has by the AAN, not supported by evidence, but supported by this data, saying maybe people shouldn't sleep alone because when they sleep alone, they're more likely to die. This carries that a little bit farther from the same study by Sveinson, looking at living conditions. And again, it correlates no tonic-clonic seizures, 1 to 3, and then greater than 4. And again, some studies say 1 to 2, 3 and greater, and others say 4 or greater. But again, if we look at the risk, sharing bedroom and sharing a household, so not only sleeping with someone, but being in the same house as someone, odds ratio 1, which is the reference. If they have no tonic-clonic seizures, 1 to 3 tonic-clonic seizures, it's nearly 16, and it goes up to 19 if you have 4 or more tonic-clonic seizures. Sharing a household but sleeping alone, odds ratio is 1. It's not really different. Here it jumps up to 31 and then to 33. So sharing the household but not the bedroom, and then not even sharing a household, so living alone. Again, 1, 1, 3.9, 15, 31, 65, 19, 33, 81. So not only not sharing a room, but living alone where nobody's even in the house to come in, the risk is even higher. So again, it raises a question, does having somebody there provide some stimulation that then again responds to, it leads to breathing? Might you call an ambulance and have a resuscitation that would help? Yes, it could, but when you look at the success rate of field suscitations by EMR, only about 5% of people who are resuscitated in the field survive. So that wouldn't account for more than a doubling of the mortality as you have here, sleeping alone or living alone, since unfortunately field resuscitation usually doesn't work. So again, it's an argument for maybe we should have people encouraged to not sleep alone, or perhaps what I've told, people not to be creepy and have their kids sleep with them, or, a sibling or somebody else, but at least you have some sort of alarm system. It could just be a smartwatch that they wear. Maybe, it could be a camera, although again, that's a little creepy because there's a little less privacy, that alerts somebody sleeping down the hall who can run in and stimulate and do something. A recent Cochrane review looking at prevention said there's, again, this low quality evidence for nocturnal supervision, so the AAN guideline recommends it. And then there's no evidence for anything else, though. So that seizure detection device that I just mentioned, there's no evidence. It doesn't mean that it doesn't work. It just means that nobody's studied it yet. There's safety pillows that people have looked at. Again, no evidence. There, in theory, is reason to think that selective serotonin reuptake inhibitors might reduce the risk of SUDEP. It's been shown in animal models. It is certainly not shown in humans. And when you look at humans who've had SUDEP and those who haven't had them, the use of SSRIs is the same. In early surgical evaluation, there's no evidence, but we know that, and I'll show you the data in a moment, that's my next slide, that epilepsy surgery reverses the mortality from epilepsy. So while there's no evidence, because nobody's randomized people to early surgery versus waiting a long time and looking at deaths, that this likely would make a difference. Educational programs, not clear. Opiate and adenosine antagonists, again, in theory might matter, but people haven't done studies in humans. And again, the one intervention not studied in controlled manner that may prevent really is controlling tonic-clonic seizures. However you do it, with medicine or surgery or stimulation, I'm going to show you that. And again, it's for the simple observation that people with tonic-clonic seizures die far more often than people without tonic-clonic seizures. And as I showed you, more tonic-clonic seizures is worse than fewer. So do existing therapies reduce mortality? How might we reduce the risk of dying? And this is my argument that you should treat your patients aggressively and don't give up. Keep trying. This is some work that I've done. This was a large series published in 2016 in neurology. The first paper that I published was, I think, in 96 or 97 in Annals of Neurology on a little under 400 patients. And I published over 1,000, and I haven't done it since because I don't see the point anymore, to be honest. So we had 1,006 surgically treated patients and 104 non-surgical patients. So they didn't have brain surgery. About half of them had DBS, and not DBS, had VNS rather, vagus nerve stimulation. We had, unfortunately, 89 deaths over long-term follow-up. And you can see the patients who had surgery, brain surgery that is, over the course of 15 years, you can see about 90% were still alive at the end of 15 years, in contrast to only about half of the patients who did not have brain surgery. And again, about half of those had VNS. So the lower mortality rate was 8.6 deaths per 1,000 person years, in contrast to 25.3 deaths per 1,000 person years, surgical versus non-surgical. So there was lower mortality with surgery than continuing medical therapy. So this is it's not a matched randomized controlled studies. It's a comparison group. It's not a proper control group. The epilepsy might have been somewhat different, but we try to control for seizure severity and other factors. And the reality is that when you look at the patients who had surgery, you would have expected them to die at this rate had they not had surgery. And that was the point, that had they not had surgery, their death rate would have been about at this rate. If we look at the people who had surgery, some were seizure-free, that is, left the operating room and never had a seizure. Others left the operating room and had one or more seizures. And again, if you look at their survival analysis, there was a difference. The risk was about double, 10 deaths per 1,000 person year versus 5 deaths per 1,000 person years, and this was statistically significant. So making people seizure-free helped, but again, 10 deaths per 1,000 person years is better than this, 25 deaths per 1,000 person years without surgery. And again, looking at the number of tonic-clonic seizures per year, and so having 1 or 2 or less than 1 are these two curves up here, and then more than 2 is this curve down here. So again, more than 2 tonic-clonic seizures in this post-op population was associated with a higher risk of dying, which again goes along with everything else. Of the 1,006 patients, 300 still had some post-op tonic-clonic seizures. And if we look at my data, you could ask me, what is the effect of surgery on those who relapsed? What was the effect of surgery on tonic-clonic seizures? And on average, the reduction in tonic-clonic seizure frequency was about 85%. So We just looked at the total number of tonic-clonic seizures per year for the population, and there was an 85% reduction in tonic-clonic seizures, even with, quote, unsuccessful surgery. That is, they were not cured. It was, in fact, quite successful because 2/3 of the patients with tonic-clonic seizures preoperatively no longer had tonic-clonic seizures after surgery. 1/3 still did, and the net reduction was 85%. So this, in part, is one of my quibbles with people publishing papers talking about failure of epilepsy surgery when people are not made seizure-free. If you eliminate tonic-clonic seizures in 2/3 of the patients, and this is all comers, but most of them were epilepsy surgery for temporal lobe epilepsy, you reduce their risk of dying because you've got rid of the tonic-clonic seizures. If they don't have tonic-clonic seizures, you still probably reduce the risk of dying, but the reduction's less. So this is what happened to the mortality. Again, number of patients, and unfortunately, you see most people after epilepsy surgery will have a seizure. But most of these people with recurrence, if you ask them, how are you doing now? 70% haven't had a seizure in the last year or two. So these are people who may have had one seizure or two seizures in the next 10 or 15 or 20 years, as opposed to many per month preoperatively. So you really couldn't call them a failure, but they have had a recurrence. But the standardized mortality ratio you see is 2, whereas the 354 who did not have any seizures after surgery, though they could have auras, the standardized mortality ratio is the same as the general population. And we know these people should have had a higher risk of dying. And again, if we look at temporal lobe surgery, the numbers are the same, which I think reflects that most of the patients are temporal lobe cases here. And extratemporal surgery, we did not find it different. And the mortality ratio in the non-surgical patients is 3.5 times greater. So that's the story of epilepsy surgery, that clearly after surgery, people do not die at the rate that you would expect them to die. And that's probably the best we can do, because the 2 randomized trials that have ever been done for epilepsy surgery basically were for about a year. And then people were able to have surgery after that. Nobody, and the numbers were small. It was, one study was 30 patients. Another study was maybe 50 or 60 patients total. There's no way that you're going to randomize a few hundred people and follow them for 20 years without offering a therapeutic procedure that can cure a percentage of them. So that's the best we can do. Now, what about other therapies? Well, this was interesting. I was involved in this work as well, with Philippe Louvlan being the first author. And this was looking at a database from Cyberonics, which was the manufacturer of the VNS device. The company is now called LivaNova. Looking at the SUDEP rate, the crude rate, and the age-adjusted rate. And what we saw was after the first 2 years, the rate of SUDEP diminished beyond what you would expect for this population. So years post-implant, once you got past 2 years, the SUDEP rate was just lower. It was, and you can see the rate was a little over 3 here. It dropped down below 2. So this was thought to be statistically significant and a suggestion that people with VNS die less often than you'd expect them, that maybe VNS reduces mortality from epilepsy. Again, it's not a prospective controlled trial. It's an observational trial. But one of the nice things when you're doing mortality research is, people can confuse you as to whether they're having seizures or not. I'm sure some of the seizure-free and non-seizure-free data that I showed you is not exactly correct. I'm relying on patient history. If they're dead or not, that we know for a fact. That you can track down. So that's quite reliable. And it looked like it was reduced. Why might this happen? It could relate to improvement in seizure control that we know happens with VNS. Also, when you do VNS, heart rate variability increases. So maybe it's an effect on the heart rate variability, which makes them less likely to have an arrhythmia. We also know that after VNS goes in place, there are changes in inflammatory markers in the brain, changes in some leukotrienes and interleukins, and maybe by reducing inflammatory markers, that reduces risk of death as well. So we don't know why exactly, but it looks like it becomes less. And if you doubt this, well, here's the RNS paper. I was also involved in this work, although this one quite minimally, I must say, for me. Of 256 patients observed over 9 years who had gone in original trials, there were 16 deaths, 4 definite and 2 probable SUDEP, 3 possible, 2 of whom were not treated with RNS at death. Of those 3, there were 2 suicides. Remember I said the rate's higher than expected, 5 other causes. So the rate for probable or definite SUDEP was 2.8 per 1,000 person years. And the pre-specified comparator was that 9.3 for surgical candidates. and 6.9 for the placebo arm of trials. So again, with RNS in place, these people are experiencing SUDEP less often than you'd expect. Similar to what we saw with the VNS patients, just a lower death rate than expected. And again, these are 2 studies. We can be dubious. Here's the third with DBS. Same finding. This paper came out about a year and a half ago. I was involved in this research as well. 8 patients died, unfortunately, during the post-implant assessment period for deep brain stimulation. 4 were SUDEP, and there was one probable SUDEP in the baseline before implant. And the definite and probable SUDEP rate was 2.1. Again, similar to those VNS and RNS rates that we saw. Overall mortality was 6.9. So again, SUDEP is a minority of the excess deaths. This is a young population, who getting DBS and RNS and VNS. So SUDEP is going to be a greater percentage. Again, 25-year-olds don't die of cancer and heart disease and strokes nearly as often, or dementia, as older people. So SUDEP is a much more important cause in younger people. And again, the overall mortality is similar to that seen with brain surgery, lower than expected with refractory patients. And this was taken from my paper, that 25.3. So the SUDEP rate was lower as well. Again, it looks like people who had DBS, lower mortality risk. And again, the hypothesis with DBS, RNS, and VNS is that beneficial effect on seizure control, certainly a role. Might other autonomic factors play a role as well? Last thing I'll talk about, and then I'll wrap up in a couple of minutes. For medical treatment, Philippe Rivlin published a beautiful paper in Lancet Neurology. He did a meta-analysis of mortality in investigational drug trials. He went through the literature, found a 112 randomized trial, and then looked at what were the death rates during the trial, during this just 12-week phase or 16-week phase for people who were assigned to drug compared with placebo. And they looked at definite, probable, or all causes of death for SUDEP. For definite SUDEP, you can see the rate here, 0.7 confidence interval, causes of the odds ratio, probable 0.17, and all cause 0.37. The risk of dying if you were in the active arm, so in the treatment arm compared to placebo, were reduced substantially. It reduced active mortality by up to 7 times. So 1/7 reduction, or a 6/7 reduction, arguing in favor of continued active treatment. So people in a trial given the drug versus placebo were less likely to die during that brief phase. And again, the mechanism, presumably reduction in frequency or more likely severity. Let's take it to my last 2 slides. Cenobamate, new drug approved a little under 3 years, actually approved a little over 3 years ago, came on the market a little under 3 years ago. The drug is different than other ones that we've seen. It appears to be uniquely effective. This is from a paper published in Epilepsy about a year and a half ago that I did. 240 patients from the phase 3 long-term trial of safety. And we were able to get data in 240 reliable seizure frequency data from a number of American sites. And you can see the percent reduction here in the top bars for focal aware, minus 83%. But again, these don't cause death. So these don't matter for death. Focal impaired aware are associated with death, a 75% reduction, tonic-clonic, and nearly 90% reduction in seizure frequency for tonic-clonic in these patients. And then if we go down below, and we'll focus on the right bar down here, what percentage of patients stopped having tonic-clonic seizures? 35%. 58% had at least a 90% reduction. 79% had a greater than 75% reduction, and a 50% reduction, even at 85%. And then the numbers are close, not quite as astounding for focal impaired awareness. So this is a highly effective drug. What we found is that at the time that the data was censored, 25% of people were 1 year or more seizure-free completely in the series. And in fact, the average period of seizure freedom was 2.5 years. So it's a uniquely effective drug. What about cenobamate long-term use in mortality? This is a project that we just presented at the AES, and the paper was just submitted this week based on this work. So of 2,131 patients, of whom 2,017 were focal. So there are about 100 patients with idiopathic generalized epilepsy in one IGE trial, followed by nearly 5,700 person years in multiple phase 2 and phase 3 trials. What happened? And again, 60% of the focal patients had tonic-clonic seizures. The median baseline seizure frequency ranged from 2.8 to 11 seizures per month in these different groups. There were 23 deaths all in the open label phase. 21 of those 23 deaths were focal to bilateral tonic-clonic seizures. There were no deaths in the generalized study. But again, like every other study I've showed you, the people who died by and large have tonic-clonic seizures, but not all. You'll notice 2 of the deaths were people without tonic-clonic seizures. There were 5 definite, and that should say or probable SUDEP. I apologize for the typo I just noticed. And of the 5 definite or probable deaths, 4 had focal bilateral tonic-clonic seizures. All-cause mortality, 4 per 1,000 person years. The definite or probable SUDEP rate, 0.8 per 1,000 person years. That's the same as the general population standardized mortality ratio. So people put on long-term cenobamate with intractable epilepsy no longer died at a rate greater than that of the general population. So the conclusion is that successful medical treatment appeared to reverse the excess mortality expected in people who have epilepsy. There's one other interesting thing I'll show you before my conclusion, and that is this, that the drug choice might make a difference. And this is a strange paper. It's a great paper. I don't understand it, though. It was published in JAMA Neurology, an excellent journal with high standards, within the year. Not long ago at all, within a matter of months. And they looked at what's your risk of dying if you were given an anticonvulsant for seizures and because you had a stroke. And it's very interesting if we look at the graph on the left and the colors, lamotrigine's on top in black, they just go down. You can see the chances of survival. And again, after a stroke, at the end of 5 years in the best group, half survived. So unfortunately, people die. But lamotrigine was associated with statistically significant with a greater survival rate than people who were prescribed levetiracetam or carbamazepine. And it was even worse with phenytoin and valproate down here. So it was kind of interesting that if you look at and they used carbamazepine as a reference drug, because that's what, I guess it's a common drug that they use in Scandinavia. That was the reference. The risk of dying was statistically lower with lamotrigine, 0.75, even adjusted 0.72. Okay. There was some overlap in the other groups with the others, although clearly phenytoin, valproic acid especially, was significantly worse. So this one you could say for certain was worse. Lamotrigine you could say was better. These 3 you could say were not worse than carbamazepine, but against comparing lamotrigine to the others, lamotrigine was clearly better. So maybe there's some effect of the drug that we choose. And we know lamotrigine is pharmacokinetically neutral, but then again, so is levetiracetam. So we would expect levetiracetam, and there's really not a difference between those 2. These others all impact liver metabolism of various drugs, and they may be worse for other reasons. So I'll conclude here. There's excess mortality in epilepsy. It's really a tragic consequence. And there are multiple factors, the etiology being critical, especially in older people, but in kids as well if they have significant morbidity. There's both SUDEP and non-SUDEP etiology. SUDEP is far less important for the population as a whole, but for younger people, it's more important. It's still a minority of the deaths, but it's important. And tonic-clonic seizures and sleeping or living alone, especially sleeping and living alone together, but sleeping alone, are strongly associated with increased risk. We need more study of pathophysiology and really good studies of prevention as well. And really, I think greater attention is required for the more common causes of mortality. Why do these people die more often from cerebrovascular disease and cardiovascular disease and neoplastic diseases and infectious causes than people without epilepsy? Their rate of death is higher from those causes. And again, I think we have enough evidence to say that we should conclude that intervention reduces mortality. Again, it's sort of post hoc analysis, but what we find is a consistent story with multiple modalities from medicine to stimulation to surgery. That is, when you're aggressive and control seizures, particularly tonic-clonic seizures, or even reduce them substantially, expected death rates reduce. So I think when that person comes in who's having 1 or 2 seizures a year and they're tonic-clonic, number one, whether they're tonic-clonic or not, that person's not controlled, and we want to think about what we do, but especially if they're tonic-clonic, you want to try to keep treating them to make the seizures milder, because you may affect the risk of dying if you can block the tonic-clonic seizures. And I will end here. Thank you very much.
I was wondering, may I ask a question?
Please do.
Oh, wonderful. Hi, I'm Michael Samus, one of the here at Kings County and Downstate. Is there any, I was actually thinking about, the use of in SIDS, sudden infant death syndrome in children and apnea alarms, and wondering if that had been looked at with SUDEP, and then also wondering, since, SIDS isn't thought of as having a seizure associated, are there any parallels between SIDS and SUDEP?
Not that I'm aware of. It's not really been studied carefully. Clearly young children with bad epilepsy die as well, and it's SUDEP as a cause, but there are other causes. But the really young ones at that age typically have the catastrophic epilepsies. So they've got enough neurological reasons, in addition to the fact that they tend to have terrible seizures and very frequent seizures and serious neurologic comorbidity. It's an interesting question with somebody with epilepsy. Should they be sleeping on their back versus their side or their stomach? And there have been some suggestions in some papers that perhaps some people who die of SUDEP are found face down on the pillow, and could some of this really be suffocation from face down and that postictal suppression as well? Again, cases that we've seen in the hospital with SUDEP, they've not been on their face in the pillow. So I think SIDS is probably a different phenomenon entirely, again, relating to autonomic instability, but it's just a different circumstance related to maturity of the autonomic regulation.
I was just wondering if the risk of sleeping alone is so high that things like apnea.
Yeah, I think it's a great thought. It's an interesting thought, and I don't know the answer.
Thank you.
There's a question in the chat.
Oh, I'm sorry. I don't have the chat up. I should have the chat up. Oh, I see. It's several questions. So, okay, so I'll run through. So isn't lamotrigine associated with higher SUDEP rate in patient without strokes? I don't know that we know that for sure. You have to be careful. You can find an individual paper that finds something, but the replicability of data is not true. And again, in that study I just showed you, lamotrigine was certainly associated with lower death rate. So I don't think that that's really the case. And here's another one: is Rolandic epilepsy associated with higher SUDEP? Is there frequent vomiting and sleep-related to seizures? And I think the answer is Rolandic epilepsy with tonic-clonic seizures can be associated with death. It's fortunately pretty rare, but it's not zero. And I don't know that it's related to vomiting and sleep at all. And then would higher SUDEP rate make placebo use in trial unethical? Yes, I agree. So for a long time in Europe, what they've insisted upon are comparator studies. The FDA has insisted that we've showed that drugs are effective and require SUDEP, requires placebo control. And their argument is that the risk of SUDEP is so low in general that in any one individual study, you won't see a difference. And you had to put 112 studies together to find that. But I agree with you. I think it's unethical. And it's not like we only have 2 or 3 drugs to treat epilepsy. There are 20 drugs to treat epilepsy. And I think for a new drug to come on the market, what we need to demonstrate is that it's better than what we have, not that what it's equal to what we have. So I think that would be required. The drug companies would much prefer comparing their drugs against placebo, because they might not do as well against carbamazepine or levetiracetam or the others, whereas they certainly would do better against placebo in most cases. So I think you have the federal government saying we want proof that it really works, and you've got companies saying we'd much rather compare our drug to a placebo than to something that we know works, because maybe our drug is no better, or maybe our drug is worse. And then we used to not mention SUDEP to parents with peds epilepsy as they're changing guidelines. And yes, the answer is that there are clear guidelines from the Academy of Neurology, the Child Neurology Society, International League Against Epilepsy, that we should be discussing SUDEP with all of our patients. Now, I think it's very difficult when somebody comes in, and I saw a new patient yesterday who presented. It was a new diagnosis of epilepsy. Hi, I'm Dr. Sperling, and by the way, you have a greater risk of dying because I've diagnosed epilepsy in you. It's a difficult conversation to have the very first time, but I think it's one of the things that I do bring up. I tend to bring up that seizures can be dangerous, and perhaps rarely, but it can happen, people can die from seizures if they're not treated, as one of the motivations for taking medication. So, motivational interviewing is important to get people to adhere to therapy, and you have to kind of go to them, so we agree you've had a seizure. Do you want seizures? We agree you don't want seizures, that you don't want to have this. And the best way to do this is to take your medicine and what's the downside. But again, you don't want to hit them over the head with a hammer. But guidelines are to tell, and people have done studies, families and patients in surveys are annoyed when doctors haven't told them, and they're generally happy that they've been told that they're aware. They're usually aware. This may be culturally determined. I don't know that it's true in every country, but in the US and in Western Europe, when people have done surveys of families generally want to know. So how does the increased death rate in epilepsy, childhood adult compare with other common chronic diseases? I can't speak to that. It really depends. There are many different diseases. So if you look at the death rate in diabetes, it's increased as well. Clearly, asthma, there's some increase in death rates. Epilepsy is about like some of them and worse than others. I don't have a comparison slide. It's a good question. I should create a slide for that and to have it. I can't give you an exact number, and I don't want to give you a wrong answer. And then you say, why more than three, or here's another question, why more than 3 or 4 convulsions don't increase mortality from SUDEP? Great question. So again, it could be that, why is there a ceiling that once you hit 3 or 4, why don't 30 seizures pose greater risk than 3 or 4? I don't think we have the answer to that. It may be that just having 3 or 4 ticks off the boxes that you need, right? I'll put that question to you. Why is the death rate from motor vehicle accidents no greater if you were driving at 1,000 miles an hour than you were driving at 400 miles an hour? The death rate's probably the same there. You're dead no matter what. It's not a great analogy, but there are other circumstances in which, once you hit a point, it doesn't make a difference. The risk is there. I think that's all of our questions.
Yeah, maybe we have time for just one more question. Does autopsy in SUDEP show contraction band necrosis?
I don't know the answer to that. What we see in the heart in many people with SUDEP is subendocardial fibrosis and evidence of subendocardial necrosis. I don't know about contraction band, but that's one thing that is reported well in SUDEP, this subendocardial fibrosis and evidence of tiny infarctions. Now, in the brain, in these patients, there's nothing striking related to SUDEP that explains it. They just have the standard findings you'd expect for somebody who had sudden death from any cause.
I think we will wrap up now. Thank you, Dr. Sperling. This was a wonderful lecture. So for a resident like me, it was very fascinating. Thank you.
Okay. Well, thank you very much for the invitation. I appreciate it. Goodbye.
Take care.